Mr. Benjamin. Benjamin Tatunga, I hope I'm audible. If you're able to hear me, please, you can react with either a thumbs up, or you can say hello or something. I want to take this opportunity to welcome everyone on the call. My name is Birungi Deusdedit. I'm a medical officer with CoRSU Hospital, and I'm part of the DMD register that we are trying to raise awareness and train everyone who will talk about this particular condition. I'm privileged to be here and also to introduce the main speakers for the day, the main presenters for the day. We have distinguished doctors, Dr. Esther Mulungi. She's a pediatrician at CoRSU Hospital, and she's also the lead investigator for this program. We have Dr. Sebunya Robert, a consultant pediatrician, also pediatric neurologist at St. Francis Hospital, Nsambya. He's also an honorary lecturer of pediatrics at Makerere University College of Health Sciences. In the same vein, he's also a senior lecturer of pediatrics at Mother Kevin Postgraduate Medical School, which is a constituent college of University of Nkozi, Uganda Matters University Nkozi. So that is the panel that we have. And for housekeeping, if you're not speaking, please, we shall have to have microphones muted. If you have any question, you could put it in the chat as the presentation goes on. Also, if you have other questions that you may want to respond to, you'll have an opportunity to be given a chance to respond to the questions at the end of the presentation. I'm going to invite Dr. Mulungi to begin, but as I do that, I'm also going to share my screen so that we're able to see the presentation together. Thank you so much.
Yes, Dr. Birungi, any issue? We're not seeing the screen and not hearing from Doctor.
Hello, everyone. Dr. Esther Mulungi. Let me just wait for Dr. Birungi to share the screen. His screen. So today we are going to basically talk about Duchenne muscular dystrophy, but as a whole, we want to emphasize muscular dystrophies among children, and we're going to really talk about the international standard. And particularly Duchenne muscular dystrophy, so that we can be able to identify these children early and link them to care, and then be able to have them improve their quality of life. We also don't know the prevalence of Duchenne muscular dystrophy, but also muscular dystrophies as a whole in the country. And so we would like to at least be at a point where we know the prevalence of this disease. So Duchenne muscular dystrophy is the commonest inherited neuromuscular disorder in childhood. And Dr. Deus, you could move on to the next slide. And it mainly affects the males. It affects the males because it's an X-linked, it's inherited in an X-linked recessive pattern. And in the inheritance, you have the dystrophin protein absent in these children. Dystrophin is oftentimes used as a stabilizer for the muscles. It helps in repair because muscles, it wears and tears. We run, we talk. As I speak, I'm using muscles. We jump up and down. We really basically do everything using the muscles. And so the muscles wear off. And as they wear off, the dystrophin needs to help us in the repair of it. But these children lack it. And so there's progressive destruction of muscles that happens in these children, and the destruction continues, and that is what gives them the muscle weakness. So Duchenne was actually first described by an English physician and by the names of Edward, and that was in 1852. However, he's really the one that it was later named after a French neurologist who was called Benjamin Duchenne, and that was in 1868. And this was after he reported a case series of boys with pseudohypertrophy and muscular paralysis. And when he did report a number of those, the disease was later named after him. But the first people to publish a paper about the myopathies in humans was Walton and Natras, and that was in 1954. And they basically looked at about 105 patients from northeast of England, and of those, 46% actually had Duchenne muscular dystrophy. And so this actually highlights the fact that Duchenne is the commonest muscular dystrophy. And that's one of the reasons why we are putting a lot of emphasis on Duchenne, because once you catch the Duchenne, or once you at least have your mind thinking about Duchenne, you'll be able, or will be able to diagnose the other muscle dystrophies. The life expectancy of these children was about 12 years. This is about 10 years ago. But after all the work that has been going on for over a decade, the life expectancy has actually doubled to about 25 years. There are some children that actually, or adults that are actually living up to about the age of 30, 32, 35, and with a better and improved quality of life, even with the diagnosis of Duchenne. So the prevalence for the muscular dystrophies is reported to be 1 in 3,500 for the adults. Dr. Deut, you can move on to the next slide. But in children, it's reported as 1 in 3,000 children. This prevalence is as of 1991 by Emery. However, in Yorkshire, it was reported as 36.9 per 100,000. And we can clearly see that all these prevalences are for Europe, and none is reported for the African setting. And that's one of the pointers as to why we are actually having to carry out this prevalence study. In a systemic review that was done by Ryder, they reported that there was a gap in prevalence and also the morbidity and mortality of these children that were affected with muscular dystrophies. And this was especially seen in the low-income countries where really nothing is being done. And he highlighted the importance of having data registries and having to compare the different countries, see what the different countries are doing and how the patients in the different countries are doing, and be able to improve their health-related quality of life. For muscular dystrophies, it's most importantly about improving their health-related quality of life, because right now the treatment is still under studies, or they're still doing studies with genetic therapies. So it's for now about improving their health-related quality of life. The global occurrence of the neuromuscular disorders is mainly for the metabolic myopathies, and then there is Becker. Becker is a cousin to Duchenne muscular dystrophy, Why is it a cousin? Why are we really saying that it's a cousin? Because in Becker, the children will also be boys. The affected children will be boys, or affected individuals will be boys. However, they will present a little later, and these boys or children actually have the dystrophy. They do not lack the dystrophy like the children with Duchenne, but they have it's not in the amounts that it should really be. So you find that their muscle weakness is not to the degree of Duchenne muscular dystrophy. There's also the congenital muscular dystrophy. This will present a little earlier when a child is still young. Some of these children actually will be those children that we might say, oh, the child actually had HIE, but really the child has muscular weakness, and then as they grow, they are having developmental delay. Most of these die off earlier on, and many times we will classify them as global developmental delay or cerebral palsy, but it will be identified earlier on in the neonatal period. Then there are the mitochondrial encephalopathies. Then there is spinal muscular atrophy that we have actually seen in quite a number of children. And then there's the congenital myopathies. There are the limb girdles. The limb girdles have facioscapular. There are about a number of classifications within the limb girdle muscular dystrophy. And one thing that we need to be, there are quite a number of children that actually have limb girdle muscular dystrophy. These children could have muscular dystrophy mainly affecting the facial muscles or the scapula and the humerus. Then there's Emery-Dreifuss muscular dystrophy. And in Emery-Dreifuss, what happens is these children will actually present earlier on with contractures. That's one thing that really separates them from the other limb girdles. They'll come in rarely with contractures. Then there's the oculopharyngeal muscular dystrophy, where it's mainly affecting the muscles involving the oculary area and the pharyngeal area. Then in the congenital muscular dystrophies, we have the Walker-Warburg syndromes, and we have the Fukuyama. Fukuyama is described more in Japan. And then you have the congenital muscular dystrophy, spinal rigidity. All these different classifications really are based on clinical presentation and clinical and history. So it's very important that when we are seeing these children, we take the history to detail. At what age did the child present? When did they walk? When did they get the speech? When did they get the contractures? When did they present with the contractures? Which muscles are especially affected? So the clinical presentation and the history is very important because it helps us to do the classification for these children with the different muscular dystrophies. So when these children present to us, we find that most of the boys with Duchenne muscular dystrophy, they'll have a delay in walking. So children should, averagely, a child should be able to walk from about the age of 10 months to about the age of 1 year and 1 year and 1 year and 5 months. But these children will actually delay to walk. But as they start off to walk, they will actually tippy-toe, or they'll walk on their toes. So they'll toe walk as they're starting off to walk. But they'll later plant the foot very well and walk excellently well. As they learn to speak, they might have a delay in speech. These are very subtle things that the mother or parents might not pick on at that point in time. But when they present at the age of 5 years or 6 years or 10 years, these are questions that we need to ask. At what age did they walk? How did they start off to walk? Currently, how are they walking? Because when the disease starts to present, which is about the age of 3-4 years, when the muscle weakness actually kicks in, they will toe walk again. And they toe walk because they have the tight Achilles tendons. They have tightening of those tendons, and so it pulls onto the limb, and then they will actually end up tippy-toeing or toe walking. With the muscle weakness, because they get muscle weakness that continues on, some of the activities that these children will be involved in will actually be affected. We know that a child who is about the age of 3-4 years, most of the things they really do is play. So you'll find that the playing is greatly affected. They will have challenges climbing up the stairs. A child who was previously climbing up the stairs very well will have difficulties climbing up those staircases. They might have challenges hopping or jumping up and about because of the weakness in the muscles. And one of the very subtle things, actually, as you see these children, you could ask them to jump, just jump, and you could jump with them. And just look at the way they jump, the way they lift their feet off that floor. The children will actually not lift the whole foot off the floor, but they will plant the foot and seem to propel themselves upward. So you think they are jumping, but the foot is still down on the toes, and the child is just propelling themselves up and down. So the jumping becomes a problem, or the hopping becomes a problem. They get a waddling gait. The waddling gait is kind of like a person who is, how a duck moves, spreads out the lower limbs and also spreads out the hands, and they have the waddling gait because they are trying to get the balance in their movement. Of course, as the weakness progresses, these are children who will have frequent falls. So the child will be reported to probably be playing football, but then they keep falling. They're running with their friends, but then they keep tripping or they keep missing a step. So the parents many times will say, this child has become clumsy, or the child keeps falling. I don't know what's going on with the child. And then we send them to do something and they take a million years to get to where they need to get to. And so it's all related to the muscle weakness. When you examine these children, one very important thing is these children have pseudo hypertrophy of the calf muscles. And this is something that was clearly described by Duchenne, the gentleman for whom this disease is named after. So they'll get pseudohypertrophy of the calf muscles. And as clinicians, as physicians, one of the many things we need to really get ourselves to doing is being able to undress this child, undress them, look at those calf muscles. They will be quite big, like that of a footballer. Look at their trunk, you can look at the picture on the right. The child will have that kind of posturing. Look at the spine. Many times they will get some sort of scoliosis, as the weakness kicks in. And ask this child to just walk towards you, walk away from the child and ask the child to walk towards you. And they'll have that kind of gait, waddling gait, but then look at the posture of the child. They propel themselves forward, so they push their chest forward, and then the back arches, and they walk on their toes. So as we have these children come in with muscle weakness, please undress them, look at their muscle bulk. They'll have wasting of these muscles, by the way. Look at the scapular areas and even the proximal muscles, they'll have wasting. Of course, as the disease progresses, because it's affecting the muscles, even muscles of swallowing and chewing will be affected. They'll be greatly affected. So the child might lose interest in even just eating because it's work for the child to chew that food and to swallow that food, because the muscles are weak, and they could later get dysphagia. So they might actually end up with malnutrition because of the feeding difficulties or the challenges that they get with the muscle weakness. One other thing, as the disease progresses, they also get contractures. If you look at that picture, you look at the wrists, you see that there are contractures right there at the wrist joint. If you're very keen, you can see that, you know, that this child actually has contractures of the wrist. And then you see arching of the left foot. They also get contractures in the ankle joint. So be very keen to look at, pick out some of these complications and be able to actually point it to a muscle dystrophy or Duchenne muscular dystrophy. The investigation. So when we pick up a child and we are actually thinking, oh, this child could actually have Duchenne, a very basic test that we could actually do is creatinine kinase. Creatinine kinase will be elevated for these children because you're having continuous muscle destruction. For Duchenne muscular dystrophy, it will be greatly elevated, more than 1,000 IUs per liter. And this is very isolated in Duchenne as compared to Becker, where the elevation will not be as high, or even in Emery, Dress-Force, and all the other muscular dystrophies. So in Duchenne, it's quite elevated in the 30,000s as compared to the other muscle dystrophies. The other test that we should be able to do is lung function tests. Why do we do lung function tests? So as the child gets progressive weakness and they especially get in the ambulatory stage, this child will later get scoliosis. And as they get scoliosis, you actually have narrowing of that chest wall space. And when they get narrowing of that chest wall space, they also get restriction in the breathing. But even as Duchenne muscular dystrophy, they get a restrictive lung disease. So it's very important that we know how their lung functions are, and also how it's progressing with the progression of the disease, because it gets worse with the scoliosis. We need to do a cardiac echo, and that's because the heart is muscle. It's really muscle, so it will be affected. They'll get cardiomyopathies. So we need to check out the heart at the time of diagnosis with children. We do a 6-minute walk test, and this walk test is to really, it just helps us know how the disease progression is and the functionality of the child and the limitation that the child actually has. For the physiotherapy aspect, there is the North Star Ambulatory Assessment Scale, where we're looking at the different functionalities of the child. And this really helps us in also planning their treatment, knowing how they are doing in relation to their muscle strength. Genetic testing is the ultimate tool that should be used in confirming Duchenne muscular dystrophy, but also other muscular dystrophies. But it's currently not available in the country. But still, if a parent is able to afford it, these are tests that could actually be run from South Africa. So think about genetic testing for the parents that could be able to afford the genetic testing, so that you clearly can know which muscular dystrophy the child actually has. The next slide clearly shows us Goer's sign. Goer's sign is a sign that we use in the diagnosis of Duchenne, because these children get weakness of the muscles. So getting up becomes a bit of a challenge. I'm going to ask Dr. Deus to play those 2 videos. So we can see that this is a young girl. This girl was seen in Dr. Sebunya's clinic. She's wearing a skirt, and she was actually asked to sit up, to stand up from the floor. So go assign, you let the patient lie down on the floor and ask them to get up. And you'll find that these children take their time to get up. So the next video shows a boy seen in the Mulago clinic. Please, you need to see how this child is climbing up, getting themselves up. They virtually climb onto themselves. So if we go back Dr. Deus, I apologize. Let's go back to the very first slide. And that slide actually gets shows us how the child gets into the prone position. Yes. So as the child is getting off the floor, this pictorial on the very left, the child will sit up and they'll need to get themselves, balance themselves out and be able to get up. And so you see how they spread out their hands and their legs to be able to get themselves up. And as they get themselves up, they bring their feet and hands closer, and then they move one limb at a time. The hand then moves up to the limbs to support themselves to get up. You see that the fifth picture shows that the boy is actually now supporting themselves by the knees. And then the next shows that the child is actually getting up, or holding on to their thighs to get up. And then finally, the child is then able to stand up straight. So this is called the goer's sign. It's a very simple examination that you could carry out for a child for whom you think has Duchenne. The other simplified way in which you could do the goer's sign is a child is seated on the chair, and you actually ask them to get up. You will find that this child supports themselves on that chair to actually get up. They will hold on to the chair and get themselves up from the chair. So we can go to the next slide. I think Dr. Sebunya has joined in. He's going to be able to answer most of the questions that are going to come in, and also supplement on what we have mentioned. So in muscular dystrophy, in Duchenne muscular dystrophy, there are quite a number of complications that we could get. We talked about the scoliosis, joint and spinal complications, scoliosis, and scoliosis will ultimately affect the breathing. We talked about the lung functions being affected secondarily to the scoliosis. Then they get the joint contractures. We talked about them, the ankle joint contractures and the Achilles tendon tightness. We talked about the nutrition. We know that as we feed, as we swallow, all those are muscles. So they could end up with dysphagia. Then they could, they get the restrictive lung disease. We did mention this, and it is very vital and very important that the children that are given a diagnosis of Duchenne actually have their lung functions done. They get a dilated cardiomyopathy, so many times we need to have these children started on captopril or enalapril. Age of onset is usually 10 years, but we start these, we start the captopril a little earlier. From about the age of 5 years, we enroll these children because you want to avoid that dilated cardiomyopathy. They die of heart issues or breathing issues. They get infections, and then pneumonias take them. They can get a cardiac arrest. So it's very important that you keep the aspect of the cardiac function in mind. They could get intellectual disability, but that's not very common in most of the boys. But also as the disease progresses, they get an osteoporosis. Now, osteoporosis, especially when these children are wheelchair bound, they will get osteoporosis, but also from the steroid therapy, which is the treatment of choice for these children, that will ultimately also give them the osteoporosis. When we have these children visit our hospitals or our facilities, and maybe we are thinking of muscle biopsy, you know, to give a diagnosis of Duchenne muscular dystrophy, or the child actually needs surgery, but then you know that the child has Duchenne muscular dystrophy. We need to be cognizant that some of these inhaled anesthetics can actually result to their death. When they are given succinylcholine, it could result into malignant hyperthermia for these children. So succinylcholine should be avoided for children for whom you're thinking actually have Duchenne muscular dystrophy. So with all these complications, we need to have these children cared for by a multidisciplinary team. We talked about the cardiopulmonary function. So that means we'll need a cardiologist, we'll need a pulmonologist. You need to look at those functions. We talked about the scoliosis, we talked about the contractures. So we need the orthopedics to come in. We need the orthotists to help us with the bracing for these wrists and the ankle joints, and to avoid them from progressing on. We also need to think of their mental health well-being. Any child who is affected by muscular dystrophy, or even and is in the teenagers, or even in the early childhood years, they go through a lot. One, they're stigmatized because they have muscle weakness. You find that sometimes we tend to say they are lazy, they are not keeping up to pace, they are not, you know. And as a child progresses, as the weakness progresses, this is the child who was previously able to do the different things that you're tasking them to do, and they knew they could do it. But right now they have challenges actually being able to do it. I can't imagine how any of us would feel when you know now you have challenges having to climb up that staircase, and you know it, and you see a staircase ahead of you, and you've got to think about it and think through how you're going to climb up that staircase. So a lot of psychotherapy needs to be done for these children, but also for the families. Imagine a mother who is having boys, and the boys are all being affected by Duchenne, or half of the boys are affected by Duchenne, because these are probabilities. You can't say all your boys will have Duchenne, no, but she could have one who is okay, and then she could have all of them actually being affected. So such a mother will definitely require psychotherapy and psychosocial support. And so it is very, very, very vital that these children and individuals actually get a multidisciplinary sort of care to ensure that everything is very well taken care of. Still in the management, the medical management, we start these children on steroids, prednisolone, and you can move on to the next one. Sorry, I kept mentioning bits of it. We start them on steroids. Steroid prednisolone, the dose is 0.7 milligrams per kilogram. That has been found to be a very safe dose for these children with Duchenne. And the Flazacort is safer as compared to prednisolone, less side effects. But still, these children could still get the ulcers, they could still get the osteoporosis, they could still get the obesity, they could still get the Cushingoid. So it doesn't completely take out, it doesn't guarantee that the child won't get the side effects of the steroids, but at least it's not to a greater extent as prednisolone. However, the Flazacort is quite costly. Each tablet is about 2,000 shillings, about that. So you find that many times the prednisolone is preferential because of the cost of the drug. Physiotherapy is very important, and occupational therapy. And in physiotherapy, we talked about the North Star ambulatory assessment tool, and this will help us set goals. This will help us know how the child is progressing. This will help us know what we need to do for the child and plan for the child as well. Occupational therapy is very vital. These are children who are going to progressively have continued muscle destruction and continuous muscle weakness. So physiotherapy, occupational therapy, very vital in combination of both. And this also prevents the children from getting the contractures at an earlier age. One thing I did mention about the steroids, when started early, try to reduce on the progression of the disease. So the destruction of the muscles, the progression to cardiac myopathy, the progression to restrictive lung disease. They've shown that the child doesn't progress as fast to get the complications as compared to a child who is not started on the treatment early enough. Respiratory care is very, 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 very vital. These children need to be up to date with their immunizations. As the disease progresses, these children may not even be able to expectorate. So when they get pneumonias, this is something that quickly and easily can lead to mortality. So when the children with Duchenne get a chest infection, it needs to be managed aggressively, because we know that it's the muscles that help us in the respiration. So you need to be able to start them on antibiotic therapy in case there are any of these three: fever, an elevated white blood cell count or CRP, increased sputum production, respiratory distress, or even a pulmonary infiltrate on the chest X-ray. Chest physiotherapy is very important once we have these children get a chest infection, and this will help us recover quick from the illness. The next slide, standard of diagnosis. Do we really need them? Do we need to have a standard for diagnosis and treatment for these children? Ultimately, all diseases, all disorders, all disease patterns need to have a standard of diagnosis and treatment, and this helps us improve outcome for diseases and also improve care and help us to have kind of like a synchronized care pattern for all patients so that there is no mismanagement. So it's very vital that we are all up to scale with the standards of diagnosis and care for these children. The importance of early diagnosis, we did mention that the average age of diagnosis is about 4 to 5 years. So we need to pick up these children early. The longer we take to give this diagnosis, the more damage there is for the muscles, because the earlier we start the steroids, the slower the progression to the disease in stage. So early diagnosis is very vital even for the families, as it gives them an opportunity to understand the genetic implications of the disease, of the diagnosis. When a family is affected by Duchenne, if a mother presents with a child with Duchenne, the kind of questions you actually ask them, you will look for Duchenne on the maternal side. So you'll ask her about her siblings. How many siblings does she have? Does she have sisters? Does she have brothers? How are her brothers doing? Are they alive? Did they pass on? If they passed on, at what age did they pass on? What was the cause of death? How were they at the age of 5 years or 4 years? Or how were they in their teenage years? So you might be digging up a lot of bad memories for the mother. And so we need to be able to still pick this out. When you have a child for whom you're thinking of Duchenne, especially dig into the maternal history. Look at the maternal uncles. It's very important. It will help us in the diagnosis of Duchenne. And in most of these diagnoses that we are doing currently for the neuromuscular disorders, we are really looking at the clinical history, the history and the clinical evaluation, because we are not able to do the genetic testing. So history is very, very, very vital. We have started a neuromuscular clinic in the country, and the clinic has been started at CoRSU Hospital. It started on the 7th of September, and we started it on the 7th of September because it is the World Duchenne Day, and we want to be able to avail care for these children with muscular disorders, not just Duchenne, but muscular disorders. We are working with Dr. Sebunya, a pediatric neurologist, so this should greatly help us and improve care for these children, and also help us to have the right protocols in place. The study is going to help us have the clinical prevalence for the muscular dystrophies, and it will also help us in assessing knowledge gaps for Duchenne muscular dystrophy among us, the health workers. So you notice that as you started, or as you tried to log into this Zoom, we asked you a few questions. We asked you about 4 or 5 questions about Duchenne, and we just want to know how much information we have, where are the gaps? Is it in diagnosis? Is it in care? Is it in, and when we are able to identify the gaps for us as health workers, we are able to improve care. And then the children are then given a diagnosis earlier on. But it would be very sad if we are educating the communities about Duchenne, and then they walk to us and we are not actually having it in mind. So it's very vital that we have these health educations. Could you be a part of this journey? Oh yes, we would love that each one of us is a part of this journey for the muscular dystrophy study and the DMD register. And the one way in which we could actually participate is by referring patients to the muscular clinic, and also helping us to improve care at our different centers, and helping us to be able to pick them up and give a diagnosis earlier on, and improve the quality of life of lives of these children. So thank you. Dr. Sebunya could supplement.
Thank you so much, Dr. Esther. That was a fantastic overview of Duchenne muscular dystrophy. Just a few things, and I think you brought all out. In the diagnosis, apart from the CK, which is about 50 to 100 times the upper limit of normal, most of the in Duchenne, we could also do a muscle biopsy. And the muscle biopsy, what are we looking for? The muscle biopsy, usually it's the stain, and you want to stain, and the stain is specifically looking out for the Duchenne to see if that protein is present. I usually tell people that the dystrophin, actually they're looking out for the dystrophin protein. And the dystrophin is like cement. If you like, your muscle, take it as a wall. And in the wall you have sand, and it also has cement. So take dystrophin as part of the cement that you mix in the sand, and you make a good wall to become firm. So if you do not have enough cement in your wall, then chances that it will collapse. And it's the same analogy that you want to bring to the Duchenne, that if you don't have enough dystrophin within, or if it is absent, there is very little cement, then your muscles are going to become weak, and eventually they will collapse, or you will have problems. So we can do a muscle biopsy. And lastly, Dr. Mulungi has talked about us doing genetics, looking out for the dystrophin gene for Duchenne. And it's important to underscore the fact that there are 2 types. It's Duchenne and Becker's mainly. Becker's is the milder phenotype, which usually begins at least towards the end of the first decade. It can start at around 9 to, or even 12 to say, even in some cases, even has been reported up to 14, 15 years. And the difference is that here there is production of dystrophin, but it is sort of partially functional. So you do not get the problems. It's like you have some cement, but they never put in enough cement, as opposed to Duchenne, where the cement is completely out. So, and what causes the 2 differences is usually the mutations. That in Duchenne, we have what we call the out of frame mutation. And this one is going to cause termination of translation. If we all remember our formation of DNA and formation of proteins, transfer RNA and messenger RNA as we are coding. So with the DMD, usually the coding, you end up going for codons that are going to cause termination. And as such, you'll have difficulty in forming the dystrophin protein, as opposed to Baker's, whereby it is an inflame mutation, whereby you don't get termination of translation to form the protein, but the protein that is formed is partially functional or is weak. So, and the clinical presentation is rather, and Dr. Mulungi has already alluded to some of them, but just to highlight that even at times the parents might not notice that this child has a problem. This might just come in retrospect, comparing to the other younger sibling whose motor acquisition has been faster, as opposed to this one who has the Duchenne muscular dystrophy. And or even language is a problem. Or so any boy and who has language delay, and there's no any other cause, you're not putting them in the spectrum, or they are not the Landau-Kleffner's or anything to explain, say, the epilepsy with the language aphasia spectrum, then you ought to do a CK. At times it could be representations of Duchenne muscular dystrophy. So far only, it's not that common, but I've seen about 2 just presenting with language delay, and they actually indeed had Duchenne muscular dystrophy. And CK, we've mentioned about it, then the waddling gait, then the falling, frequent falls and tripping. And if you have the frequent falls and there's a history that the ankle, maternal ankle, because Duchenne is X-linked, Duchenne Baker's, then chances are that if you have, especially paternal uncle, either one died or there were those who had similar, mom could have been the younger sibling, and he saw his elder brother having such similar problems like his son now. It is important to ask that history, especially in our setting where diagnosis is not readily available. The history could come in handy, especially from the maternal side. So Dr. Mulungi has brought it all out. The management is all known, whereby you have to do the lung function tests. You have to do, if you have manage the bone mineral densities, but even a spinal x-ray is good enough, because you are going to give this patient or this young boy steroids that could cause osteopenia and even end up having pathological fractures. So you need to do x-rays of the whole spine. And mothers with children who have, there's a lot of data and evidence that mothers ought to be checked out, or they're supposed to see a cardiologist. Mothers with boys who have Duchenne muscular dystrophy, they ought to see a cardiologist as well. So whilst you are having the boys taking care of them, you need to also refer the parents, the mother, biological parents, to the for a cardiac checkup, especially doing an echo, to make sure that their hearts are also in a good function state. I think we shall welcome questions if there are any questions. Dr. Mulungi has brought out most of the nuances of Duchenne muscular dystrophy. So she has brought them out very well. So one thing I always tell people is that dystrophin or the ones where the muscle disorders where you have a raised CK, most of them are destroying dystrophinopathies. There could be very many. You could have the limb girdle muscular dystrophies, the congenital muscular dystrophies, the Emile-Dreyfus, the rigged spine. Those ones will have elevated CK. Whilst the ones that you don't have elevation of CKS could have this, but those ones begin early. Those are the congenital myopathies that could say the central nuclear, central core, nemaline lead, fiber disproportion. So those are some of the things that you want to talk to when you are faced with a patient with a muscle problem. And also when they come to the clinic, what do you want to have when they have come to the clinic? And yes, you've confirmed that this is a patient who has a muscular problem, and yes, he has muscular dystrophy. First, find out if they are sleeping very well. Some of them can end up having what we call nocturnal hypoventilation. So you want to know if they are, especially those ones who have become wheelchair bound, how many pillows do they use when they are sleeping? Are they turned in bed? And if they're turned in bed, how many times? Then if they're being turned a lot and they can't, then you want to know during the day, do they have somnolence, or are they sleepy? Do they have headaches? When a Duchenne patient comes and tells you during the day they are presenting with the headaches and they are sleepy, then you know we are most likely we are dealing with the nocturnal hypoventilation. These are the ones who need to do sleep studies, and eventually even they might benefit from BiPAPs, especially when they are sleeping. Then the bag, what they are using, especially if they are having a wheelchair. If they are having a wheelchair, you need to give a wheelchair that is straight, where they sit at least in a form of a 90 degrees, so that they don't sit and at an angle that is going to predispose them into getting scoliosis. Like Dr. Mulungi said, scoliosis can eventually end up giving them restrictive lung disease. It's a problem. And with Duchenne, yet remember you're giving them steroids. If they get this scoliosis, it's a problem even to correct. So we need to also emphasize on the wheelchairs they are using. Don't give wheelchairs that have a lot of space where they can sit in any angle. They need straight wheelchairs to prevent scoliosis, depending on where it's concave to and which degree it's the degree of the scoliosis. Then the contractures, the tears, if they are very tight, can they go to 90? You want to see how far, do they have a rigid spine? How far you can help them. You need to do, if they're having contractures, this can cause pain, especially when they are sleeping in the night. So you might need to have good occupational and speech therapy and even physiotherapy. Don't forget a dietitian. This is a multidisciplinary approach, dietitian, because they are taking steroids that are going to increase their appetite. And when their appetite is increased, yet they are not ambulant, most of the time, if they have gone into wheelchairs, they are going to become obese. So we need to be cognizant of some of the side effects of steroids, hypertension, obesity, and follow them up putting at the back of our mind of those possible complications. Thank you so much. We shall welcome questions.
Thank you, Dr. Sebunya, for the supplementation. It was wonderful. So one of the questions, Dr. Deus, are you reviewing the questions? But one of the questions is enrollment free of charge? Yes, for now, as the register is ongoing, we are enrolling the patients at no cost. They'll be able to see the doctors at no cost, and they'll also be able to get the medication. So we are offering them the steroids. We are also doing the lab tests, the creatinine kinase. We're not able to currently do the genetic testing because of the cost. And we're also going to start to do their lung functions. That's a component that we are adding to the clinic aspect. So yes, send them in. The enrollment is free of charge, and the clinic runs on every last Saturday of the month. For this month, the clinic will be held on the 26th of October. For next month, it will be held on the 30th of November. So every last Saturday of the month, we are seeing these children. Yes, the next, the other question was, how do you differentiate Duchenne from cerebral palsy? I'll answer a bit of it, and then Dr. Sebunya will supplement it. One thing about Duchenne is, one, it mainly affects the boys, Duchenne and Becker. The other muscular dystrophies can actually also involve the girls, okay? But for Duchenne, it's mainly the boys. These children will have delayed in walking, delayed development, but they will later walk. But as they start off to walk, they'll tippy-toe, but they'll later plant the foot. But it is as they progress that you'll find that the child is now tippy-toeing again and getting weakness of the muscles. In cerebral palsy, depending on the cause, because we know that a child could actually be doing very well, but then they get a febrile illness, they get a meningitis or a cerebral malaria, they get an encephalitis, and that could hit them down to cerebral palsy. So history is very, 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 very important for us to be able to differentiate cerebral palsy from Duchenne muscular dystrophy. Is there a maternal history of the same presentation of muscle weakness? When did this child present? Remember, Duchenne, they start off from the age of about 3 to 5 years. Cerebral palsy, if it starts earlier, if the child has had HIE, the child has had hyperbilirubinemia, canicterus, if the child has had the neonatal meningitis, if they were preterms and they had a stormy neonatal period. So the history, try to tease out all those different aspects and be able to know, is this CP, is this actually muscular dystrophy? Epilepsy could also present in cerebral palsy. Not something that you will see in Duchenne muscular dystrophy. So that's one thing that will clearly tick it off. I don't know what else I could quickly talk about in relation to, and then also creatine kinase, like the elevation will not be as much. Will not even be as much, will not really be there in CP. So history, and clinical evaluation. You won't have pseudohypertrophy in CP, and you will have it in Duchenne muscular dystrophy. Yes, as CP progresses, the children will actually also have the scoliosis, can get the scoliosis, but this will be something that will present later on as the muscle weakness also comes on. The contractures can be in both of them. So yes, there are a few features that could be in both of them, but history is very, very vital. Dr. Sebunya, you could supplement on that?
No, I think you've brought it out very clearly. The issue is history. These are two different things. The one who asked the question, in Duchenne, you have otherwise a normal child. This is a child who is born normally, is a boy, he's been okay, then suddenly starts to fall, tripping, gait abnormalities. Whilst in cerebral palsy, as even the definition goes, cerebral palsy is a disorder of movement and posture due to a non-progressive insult that occurred to a fetal or developing brain. And it's associated with either movement disorders, muscular disorders, epilepsy, cognitive impairment, vision. That's the new terminology and definition. So it is too different from Duchenne. So you just get the history that you've alluded to. The history of Duchenne is a child who's been very normal. I want also to demystify the fact that people, when they see a child with when you have a child who's been very okay, he's 5 years and he gets, say, cerebral malaria or an encephalitis, he comes down with a sequelae. At times, many people may want to refer this child to be having cerebral palsy. That's not cerebral palsy. That is, we could say, that is a sequelae of that infective insult that happened. In CP, we still denote that it is a fetal or developing brain is affected, and the causes may be many. Could be your HIE and the child comes in with a small head, or could be even canicterus. It could be other developmental encephalopathies. You have neuromigration problems, and you end up having cerebral palsy. Dr. Mulungi, I hope we are clear. It is history like you've pointed it out. They are two different things. Another question?
So thank you so much, one for the presentation and some of the questions that you've answered. I want to quickly run through the chat, pick some of the questions that we could have left out, and then I will allow Timothy who has raised his hand, to be able to speak to us. And I will ask Timothy, if I give you an opportunity, you try to be snappy. Let me go through the questions. The first one that someone asked that I think didn't get answered was, Wilson Tenyo was asking, how is the onset from walking normally to failure to walk? Is it over a few days or months or years? How long does it take to develop the fetal cardiac and respiratory complications? That's one. I would request that we bundle them together, since we are already on top of the hour. That is from Wilson Tenua. The second one is
So Dr. Sebunya could be answering the aspect of how long does it take to get the cardiac complications as you get the other questions.
Yeah. Dr. Sebunya, you can take on the mic.
So the cardiac complications, usually by around 10 to 15 years, they've started having these cardiac complications. They have already set in. So even at the respiratory complications, and respiration actually is affected more by the cardiac. And so that's why we have to avoid the scoliosis. If they come in, remember, scoliosis will come more if they are not ambulant and they are seated in a wheelchair, which is ill-fitting. So many will describe and tell you it's more described around 14 to 15, but it can go as early as about even 10 years, because let's remember the typical age group will be 2 years to 5 years of tiptoeing, of falling. Then they stabilize a bit, the natural history. By around 7 years, they get some bit of pseudo stabilization. Then for about 3 to 4 years, then by around 9 years, they start, if you do not intervene. But now things have changed. When we start steroids, actually the manifestation of these go on now. The age at which these complications set in has been extended if you start the steroids early. That's why when you have a child who has Duchenne muscular dystrophy, clinically, please start steroids.
Thank you very much. The other two questions, one is still from Wilson Tenyo. He's asking, does DMD occur in isolation, or it's can occur with other syndromes? Then the other question is from Bashir. He's asking, could you throw more light on the inheritance and genetic counseling for parents with the child? And then the last one is, how do steroids work in this case? So those are the three questions from the chat. You can respond, then Timothy will speak.
So what was the first question was what? Again?
Does DMD occur in isolation, or it occurs as part of other syndromes?
So DMD most of the time may occur in isolation, but there are some syndromes. There are some children with DMD who have autism, and it's been described, and some even have cognitive impairment, but most of the time it may occur in isolation. We have to differentiate it from other muscular dystrophies like the brain, eye, and muscle diseases, which are the congenital muscular dystrophies. and which present with other epilepsy, and they have behavior problems, and some cannot walk, have delayed walking. So most of the DMDs occur in isolation, but we know that the dystrophin protein is also in the brain and in most of the muscles, and also in the brain. That's why people may end up having cognitive issues. The other question?
The other question was asking about genetic counseling for parents who have a child with DMD.
So it is very vital that NHR, because DMD is an X-linked recessive disorder, meaning that the affected children will get it from their parents, especially the mothers. That's why I said even the mothers, why we need genetic counseling, even the mothers need to go and see a cardiologist. That's one. Then it also affects the family. There are chances, I've had families that have 3 to 4 boys, all have Duchenne muscular dystrophies. So this takes a toll to the family. So you need to put them to the table and look and say, this is a condition, it's inherited, it's maternal. So it's like, I could say, it's like mitochondrial inheritance. It's not mitochondrial, but it is maternally inherited because it's X-linked. So the genetic counseling comes in because of its mode of inheritance, that there are chances that you may produce other children when they have Duchenne as well. And we know all the things that this is a non-incurable disease as of now. And so the two parents, both the father and the mother, need to come to the table, and we discuss all, even the long-term thing, the schooling, the psychosocial, it's a multidisciplinary kind of disease management. There will be depression from the boys. They will say, but why me? Why am I in a wheelchair? Why am I doing this? You need a psychiatrist. You might need to go and foot some bills to get a good wheelchair. The steroids may be expensive, especially the Prazocort, which is slightly expensive. And the parents may ought to go for that. So there are a lot of dynamics that may come through. So you need to come to the table with them and tell them what happened. That's why ideally you need to have a genetic counselor in a DMD clinic. Then lastly, how do the steroids work? The exact mechanism is not yet very well elucidated, but we think they sort of delay the fibrosis because this pseudohypertrophy. What happens in the Duchenne, because we do not have enough dystrophin, so when you have the forces, when the muscles are contracting, they wear and tear because it's not firm enough. I could bring that analogy. They tend to release creatinine kinase, that enzyme. And when they release it, and when it's released with also some endopeptidases and calcium, all these ones go in and cause fibrosis. And so steroids sort of delay this process of fibrosis and the fat replacement of muscle. But that's what is being alluded to, the mode of action and the mechanism of action.
Okay, thank you so much. We're going to have Masava as the last one. Masava, please be snappy. We are out of time, and because we want to wind up this session, we are out of time.
Everyone, thank you for this presentation and this particular topic. My concerns, others have been addressed, but let me be brief. One, I'm going to look at community engagement or recruitment. I have a daughter with a muscular dystrophy, but it took me years and years for me to get a diagnosis. I'll not go deep there. But now the challenge is at community level. How do we tell people? Because me, when the child made 4 years, my girl reached 4 years, then started walking in a funny way. Then issues came up the wrong immunization, vaccines were poor, your mother did this, such a funny myth around before we go to hospital where there is genetic counseling. That's one. And two, how do we involve the government? I've seen people of autism, they have campaigns, they do walks, they do what, but for us, we are totally eliminated. In public system, there is not even a single screening pertaining that, because for me, I spent and spent and spent, and I made the diagnosis by error. I had gone to IHK, then there was a Russian drug addict who saw my daughter and said, this thing happens in Russia. It is called so-and-so. It's when the physicians picked it up, did a biopsy and the rest of other things. Then the matter of school. My daughter is 18 years now, but I'm struggling with the school, getting schools which can accommodate every other person, and how to make the rehabilitation all in all. I was told that my child would be dead at the age of 12. The mother lost hope. I've been struggling as a father. So I don't know how we can have this campaign come as a comprehensive package to our society. Thank you.
Thank you very much, Timothy. Those are very important and valid concerns. I'm going to request Dr. Mulungi to take the mic, and then after Dr. Mulungi is done, Benjamin, you'll come in with the last session to close this. Thank you.
Thank you, Timothy. Your daughter, being that it's a girl, most probably does not have Duchenne, but has a muscular dystrophy. You could come in and we have a look at her with Dr. Sebunya, and then be able to probably give a clinical diagnosis. And one of the other things that we could do to make sure we have the actual diagnosis is genetic testing, but we mentioned that it's not available in the country. But you could come in on the 26th of October, and Dr. Sebunya takes a look at the child and has an evaluation for the child, and then we have a plan. About school is definitely very tricky, very challenging for the child. One, also for access, but also because as she goes around school, there could be quite a number of challenges. I would love for you to know that she can still do school. So I would kindly request that you keep her in school for as long as the school can keep her there. If she's not able to walk, get her assistive devices. If she's still able to get around the place, please let her get around the place, because we usually want to keep them in an ambulatory state other than having them in the wheelchair. So please ensure that she's having the therapy, physiotherapy, occupational therapy. It's very important so that she doesn't get the contractures and to also help the muscles. So I would request that you come in on the 26th of October at CoRSU Hospital. The campaign, we are doing a countrywide campaign. We are, of course, now mainly focusing on the health workers. We need us as the health workers to be able to identify these children with muscular dystrophy early and link them to care, start care, and improve their quality of life. However, we also are doing a countrywide campaign. We did CBS last month. This month, we are trying to do a few other radio stations, and next week we'll probably have Sanyo on board. We had an interaction with them today, and maybe radio, but it comes with a cost, and these are costs that we, of course, want to be able to meet. But the most important thing is we want to focus on providing care for these children and not putting a lot of money in radio. So yes, we're trying to do the campaigns, We are doing most of it online. There are Twitter handles, there's LinkedIn. So Dr. Deus can share those links, and then you could get on. We are providing a few some information about the muscular dystrophies and Duchenne to increase awareness. With the Ministry of Health, we've visited the Ministry of Health. We've had a few conversations with Dr. Olaro and Dr. Upentho, who is the head of community health. And these are conversations that we need to get started, because when we don't get them started, they can't think through them for us. We need to know that we don't know the prevalence. So you also can't shoot a gun to the Ministry of Health because they don't know the disease burden. So let's start off with knowing the prevalence and then be able to advocate for a lot more. You can join the campaign and we see how we could help you more, but come in, get psychosocial help, speak to Dr. Deus. Dr. Deus actually has a muscular dystrophy, but you could come in, and he's gone to medical school. He's a doctor now, so don't take your daughter out of school. I think that's basically it. Dr. Sebunya could supplement if there's something I've left out for your daughter specifically.
No, I think you brought it loud and clear. The fact that we are even on this forum, he has ably said it was a diagnosis by mistake where a Russian said that disease is in Russia. So that meant that we, the health workers, are not very well equipped with this kind of disease or muscle condition. So by doing this, we're already trying to bring out the campaign so that even the health workers in the community, because you see, he moved everywhere till by mistake. That means we never knew the condition very well. And when we are armed with the information, then we can easily identify. With the neurological conditions, most of them, because are a bit rare, especially the rare diseases, people will say, like doctor said, they did this and this. It's because they are ill-equipped. They do not know about this. So it is incumbent on us to inform them that this is a muscle problem, this can happen, and you can only inform the community when you have the information. So I think, Dr. Mulungi, you've answered the question very well.
All right. Thank you so much.
Thank you very much. Benjamin, you can take over. Thank you so much. I want to appreciate everyone who has been on this call. And for the dates of the clinic, we run on 26th of this month, which will be Saturday. And then on the 30th of November, it will also be a Saturday. And it's a multidisciplinary clinic. Thank you so much.
Yes, thank you so much, Dr. Deo, for being a perfect moderator. And thank you to Dr. Esther and Dr. Robert. Let me invite our CEO, who spoke with the forum, to give the closing remarks. Over to this, Mr. Moses Changwa.
Thank you so much, Benjamin. And thank you so much, our facilitators tonight. It's always a pleasure for us to host you. As Busoga, and maybe the country at large, we are struggling with a lot of ignorance, especially as we serve our people. So having some of these sessions to enhance our skills and also clarifying a few things here and there, you are doing a lot of important things, save lives. We are so grateful and we thank you for sparing your time, and we shall be inviting you several times to come and make a contribution to improving the capacity of health workers, especially here in the Busoga sub-region. And as Benjamin could have taken you through, we are running as a membership organization, so we want to thank you and want to invite you people to keep supporting the forum. We have different categories of membership. People who want to be lifetime members, institutions that want to join us, and video members only pay 100,000, institutions pay 500, and lifetime membership is 1 million. So you're welcome to making a change in this Busoga region. We want to also take this opportunity to appreciate you, especially Dr. Esther Mulungi, for your dedicated time that you spared to making contribution to today's presentation. And we thank you so much. And on behalf of our chairman board, Dr. Peter Weiswa, we want to thank you so much and we give you this token of appreciation that communicates how we feel about this session. And to Dr. Roberts, it's been wonderful. You made things quite clear and the audience has appreciated. So we thank you so much. And we also give you a token of appreciation for your dedication and the time we spent contributing to knowledge contribution in this region. And lastly, Dr. Birungi, we thank you so much for guiding the discussion and making sure that we have this important.
Yes, I can just speak it from there. So Dr. Birungi, thank you so much. And maybe Dr. Robert and Dr. Esther, if you have any last words, you can just say them and we can go into the weekend.